Hey everyone, and welcome to a special explainer for the Griefology channel. Today, we are diving into one of the most common and, honestly, one of the most challenging images in all of medicine, the chest X-ray. For millions of people, it's the very first look inside their body, but figuring out what it's telling you, well, that's both an art and a science. Okay, just think about this for a second. You've got all these complex 3D structures, the heart, lungs, ribs, all your blood vessels, and they're all squashed down into one flat, two-dimensional picture. It's just a jumble of overlapping shadows. So, faced with that, how on earth do you find one tiny crucial clue to a diagnosis? Well, the answer is pretty simple. You don't guess. You use a system. A solid, repeatable system is what makes the difference between a confident read and a really dangerous mistake. And that's exactly what we're going to build together, step by step. First, we'll talk about why having a system is so important. Then, and this is crucial, we'll learn how to tell if the X-ray itself is even any good. After that, we'll take a guided tour of the anatomy, learn to decode the lungs, talk about what happens when X-rays just aren't enough, and then we'll wrap it all up with a checklist to tie it all together. So, why do I keep hammering on this idea of a system? Because a system is what turns that confusing mess of black, white, and gray shadows into a readable map of the chest. It makes sure you check every single critical area, every single time. It's how you minimize errors and make sure those super subtle but really important findings don't get missed. It's all about bringing order to the chaos. And the stakes here are incredibly high. The chest X-ray is the go-to imaging tool in the emergency room, in the ICU, before surgeries, even just for routine checkups. It's used for everything from checking the placement of a breathing tube to looking for cancer. So yeah, getting the read right and getting it right quickly is absolutely vital. So where does our system actually begin? Well, before you even think about looking for a problem, you have to ask a really basic question. Is this even a good picture? It's a step people often skip, but a poor quality X-ray can make you see things that aren't really there. Or even worse, it can hide problems that are. To make this super easy, there's a quick mnemonic that radiologists use all the time. RIP. And no, not rest in peace. It stands for rotation, inspiration, and penetration. This little check helps you assess the three most important technical bits of the X-ray to make sure it's actually worth reading. So let's break that down. First up, rotation. You want to see if the patient is twisted. You do that by checking if the spinous processes, those knobby bits of the spine, are dead center between the collarbones. Next, inspiration. Did the patient take a deep enough breath? You should be able to count between 7 and 10 ribs on the back. Then, penetration. Is the X-ray too dark or too light? The sweet spot is when you can just faintly see the spine through the shadow of the heart. And of course, you check the positioning to make sure the shoulder blades aren't blocking the view of the lungs and that there is no motion blur making all the edges fuzzy. All right, so we've got ourselves a high-quality image. Now the real fun begins. We are going on a guided tour of the anatomy, using another mnemonic to make sure we look at everything in the right order. This is where the real detective work starts. And our roadmap for this little tour is the classic ABCD method. It's super simple and really effective. We'll start in the middle with A for airway, then work our way out to B for bones and soft tissues. Then we'll check C for the heart, D for the diaphragm, and finally we'll get to E for effusions and the lungs themselves. First up, A is for airway. We're looking at the trachea, which is that dark, air-filled tube running right down the center of the chest. On a normal X-ray, it should be perfectly straight, right over the spine. If you see it getting pushed or pulled to one side, that is a major red flag. It could mean something big is pushing it, like a tumor, or that a collapsed lung is actually pulling it over. Next up, B is for bones and soft tissues. You want to carefully trace every single rib you can see. Look for any breaks, any weird spots, or anything that looks out of place. Check the collarbones, the shoulders, and the bits of the spine you can see. Then have a look at the soft tissues outside the ribs. Are things symmetrical? Is there any strange swelling? The bony cage really does tell its own story. Now on to C for the cardiac silhouette and the mediastinum. That's just the central part of the chest that holds the heart and all the big blood vessels. The first big check here is the cardiothoracic ratio. Basically, the heart shadow shouldn't take up more than half the width of the entire chest. If it's bigger than that, it might be a sign of heart failure. You also want to look for nice, smooth borders around the heart. Oh, and a little pro tip, check the hilla, which is where the vessels go into the lungs. The left one is usually just a little bit higher than the right. And this is a perfect example of why knowing your anatomy is so important. Let's say you see a weird shadow or some widening up in the front part of that mediastinum, Well, knowing this fact immediately helps you narrow down what it could be. It's that combination of seeing something abnormal and having the anatomical knowledge that gets you to a diagnosis. D is for diaphragm. That's the big dome-shaped muscle that separates your chest from your belly. You'll notice the right side is usually a bit higher than the left, and that's because your liver is sitting right underneath it, pushing it up. But the most important thing to look for here are the costophrenic angles. Those are the sharp, pointy corners where the diaphragm meets the ribs. You want to see those angles looking crisp and sharp. If they look blunted or kind of rounded off, that's often the very first sign of a pleural effusion, which is just fluid building up around the lung. And that brings us, finally, to the main event, the lungs themselves and the space around them. This is usually the most complicated part of reading an X-ray, where we really have to look for specific patterns of disease. Okay, so the lungs should be mostly black, right, because they're filled with air. When you see white areas, or opacities, we tend to put them in two big buckets. On one side, you have airspace disease. This stuff looks kind of fluffy or like clouds. It happens when the little air sacs get filled up with fluid or cells, like in a classic pneumonia. You might even see these dark, branching lines inside the white cloud. Those are air-filled airways called air bronchograms. It's a dead giveaway that the problem is in the air sacs. On the other side, you have interstitial disease. This looks totally different. It affects the lung support structures, so you see a pattern of fine lines or tiny dots. This is what you'd see with things like lung scarring or fibrosis. Now, besides those big patterns, we also look for single, focused spots. And when we find one, size really, really matters. If you see a round spot and it's 3 centimeters or bigger in diameter, well, we call that a pulmonary mass. And unfortunately, a mass like that is considered cancer until proven otherwise. But this really gets at one of the key limits of a chest X-ray. It's fantastic for detection, for finding that suspicious little spot or nodule. But it's not so great for characterization. To figure out if that spot is dangerous or not, you almost always need to bring in the big guns. We also have to check that space around the lung, the pleural space. The two big things that go wrong here are a pneumothorax, or a collapsed lung. That's where air gets into that space, and you can actually see the edge of the lung pulling away from the chest wall. The other big one is that pleural effusion we mentioned, where fluid builds up and blunts the sharp angles. And sometimes that fluid can get trapped in pockets, forming a loculated effusion that almost looks like a tumor stuck to the inside of the chest. And that leads us perfectly into our next topic. Look, the chest X-ray is an amazing first step, but it definitely has its limits. When the picture isn't clear or when we need to see way more detail, we have to turn to more advanced imaging. And most of the time, that means a CT scan. So how do you choose? Well, think of it this way. A chest X-ray is fast, it's cheap, it uses a very low dose of radiation, and you can get one pretty much anywhere. Its biggest weakness is that whole 3D squashed into 2D problem. A CT scan, on the other hand, gives you these incredibly detailed cross-sectional slices of the body. It's amazing for finding tiny, subtle problems. So what's the catch? It costs more, takes longer, and it involves a much higher dose of radiation. It really is about picking the right tool for the job. Phew! We have covered a ton of ground, from checking the quality of the image to the nitty-gritty of the anatomy. So now, let's put it all together. Let's consolidate everything we've learned into one simple, practical checklist you can use every single time. Here it is. This is your game plan. Number 1, always check the technical quality first. Use that RIP check. Number 2, start your systematic ABCD tour. Then just ask the questions. Is the airway in the middle? Are the bones okay? Is the cardiac shadow a normal size? Are the diaphragm angles sharp? Are the lungs clear? And if they're not, what's the pattern? And only then, after you've checked everything, do you form your overall impression. If you follow these steps, in this order, you will build an incredibly powerful and reliable habit. And that brings us to one last thought, something to chew on for the future. We all know that AI is getting scarily good at spotting problems on images like these. So, as these algorithms take over more and more of the raw detection work, what does that mean for the human expert? Will the radiologist's systematic, context-aware human eye become more important for putting all the pieces together, or less? It's a fascinating question, and the answer is going to define the future of this field. Thanks so much for watching.